Good evening, sir. And good evening to all the participants. They must be surprised since Dr. Asani sir is not here, but he had to travel. So at this last moment, he was not there, and I get the honor to introduce you, sir. And he has given me a big note. He said that he's a dear friend, and you do it pretty well. I said yes, sure. So I welcome you, and as sir has written, Dr. Suhas Prabhu, one of the best well wishers of our webinars. Renowned pediatrician attached to PD Hinduja Hospital, infectious disease expertise. It helps that he and Sir were classmates at GS Medical College in 70s, and whenever we have approached him, he has never said no. This is with the knowledge that Sir only conducts CME for the pediatricians and not family practitioners. But he has honored us by taking our 50th webinar on fevers in children and then 88th webinar on approach to cough in kids, prescribing a cough syrup. And now 168 on role of point of care test in practice. He has a list of awards. If I mention them all, I think we will run for an hour. The latest accolade which has been showered on Sir is the Lifetime Achievement Award by Indian Academy of Pediatricians. So many congratulations on this latest feather in your cap. Friends, I present to you Dr. Suhas Prabhu, sir. A most rational pediatrician is what Sir always mentions. Welcome, sir. Sir, you're on mute, sir.
Thank you, Dr. Sushma. And I was hoping to see Dr. Asrani online, but I met him last Sunday, so it's okay if I don't see his face. Thank you for doing the honors. And thank you for inviting me again to speak on a topic for your Amara Health group. Yes, you are right. I take mostly lectures for pediatricians, and I must have taken over 1,000 lectures for pediatricians so far on different topics. But I have taken a few more outside the Amara Health group for general practitioners. But yes, the number is very less. It's in single digits. So, but Asrani is a dear friend, so I cannot say no to him. So thank you again for inviting me. So, and thank you also for allowing me to choose the topic that I suggested. And the topic is, I'll start sharing my screen.
Yes, sir.
Okay. What I'm going to talk about today is on point of care tests. And I have subtyped it as hope or hype. Because, whenever something new comes in the market, it brings with it great, shall we say, hopes of a better life or a better practice or a better experience. And sometimes this all turns out to be fake or just a hype. So let me see if I can point out to you what is the hope or the hype on point of care tests. So before I start, just to clarify, what are point of care tests? So let's sort of define them so that we know what we are talking about. They are defined as medical tests that are performed at or near the site of patient care. So that's the first step. It has to be done next to the patient. So the patient doesn't have to go elsewhere like he goes for a CT scan, or he doesn't have a blood sample collected, sent to a lab and a report comes. It is done at the bedside of the patient. The second aspect is that it is generally done by the physician himself or herself. So obviously it's going to be something that is small, handheld instrument or a kit. And also, of course, it has to be pretty simple to use so that physicians can conduct the test reliably himself or herself. So this is what a point of care test is. And the whole idea of a point of care test is to collect the specimen from the patient and obtain the results in a very short period of time. Typically a turnaround time of, a few minutes, maybe 10 minutes or 15 minutes at the most. Maximum, I would say, would be half an hour, because otherwise the patients or the doctor's patients will run out. And the whole idea is that you adjust the treatment plan as necessary before the patient and the physician separate. Now, why do I mean by this? If, for example, it's on an inpatient and you are taking rounds as a physician, then you want to get the result before you leave the patient to go to the next patient. And on the other hand, if it's on an outpatient basis, then of course it's the physician who's sitting in the consulting room. The patient is going to leave in a few minutes. So we need the answer to the test or the result of the test before the patient wants to leave, which is typically 5, 10, or 15 minutes. Nobody wants to stay for an hour in the doctor's clinic. So that's the whole idea of a point of care test. Now, we should really think of point of care tests as a part of a clinical examination. And we have used certain instruments or kits for doing certain tests on patients. I've been doing it for a long time and never really thought about the fact that this is a test that I'm doing on the patient, besides just asking the history and doing a physical examination with my hands and my eyes and my ears. This is what we use for examining a patient, the physical clinical examination. So they should be thought as an extension of the physician's assessment, which would be history and physical examination. And some of the tests that we've already been using, for example, is a blood pressure instrument. We've always used a blood pressure instrument. I mean, all of you must have been using for years. And recently, after the COVID epidemic, many of us have started using a pulse oximeter for measurements of a transcutaneous saturation of oxygen level. And of course, this idea, really speaking, is a lab test. In the old days, we would collect a blood sample, an arterial blood gas, send it to the lab and get a result, which would tell us what would be the saturation of oxygen in this particular patient. Now we are doing it bedside of the patient using a very small instrument that you see here. All of you have seen this instrument, which we call a pulse oximeter. So these are kind of an extension of a clinical examination of the patient. So having discussed what a point of care test is, this is what I'm going to cover in today's talk. The first is, what are the advantages? Why do we need point of care tests? Why are they so relevant? Why are they so important? Why are they so good? Secondly, we'll talk about some of the commonly used tests. And here I must mention my bias that I'm a pediatrician. So many of these tests will be one that we use in pediatrics. Of course, some of them you can use even in adults. And also the fact that since I am more interested in infectious disease, I will be talking a lot about tests that we use for infectious disease. Of course, point of care tests are also available for non-infectious disease, but I will not be talking so much about that, but I think you can extend the principles to that. Third, I will talk about what is the future of point of care testing. Where are we going? And lastly, whatever is available now, how do we look at them? How do we use them judiciously, and how do we make use of them in the best interests of the patients and our practice? So let's start with the advantages of point of care test. And of course, the most important advantage of a point of care test is you have a quick and reliable bedside diagnosis. Obviously, this will result in a more rational medical treatment that is based on the evidence of a test or tests rather than using clinical judgment alone. So if, for example, I think a patient is come with fever, he's looking toxic, he's eaten bhel puri 1 week ago, now he's got a tumid abdomen, he's got very poor appetite, he's got a coated tongue, he's got a liver and spleen enlargement. Yes, I know this most likely is typhoid. But if I have a test that I can do bedside that tells me that this is a salmonella infection in 10 minutes, then obviously I will be doing more correct rational treatment for typhoid, because very occasionally such a patient may not have typhoid and may have some other disease. So you have objective evidence, what is called evidence-based medicine or EBM would be possible if we have a bedside point of care test. Now, besides the fact that you get a quick identification of the diagnosis, there are various other advantages of point of care tests which initially are not very obvious. One is, of course, the positive patient identification. And you may say, what is this? And this is something that anybody who's run a lab or running a hospital is always worried about. You collect, for example, a urine sample or a blood sample, and you send it off to a lab to do a test. Since you're not doing a point of care test, it goes to a lab. And you're always worried whether the sample is identified correctly. Who puts the label on that sample? The nurse, the ward boy. Sometimes the label comes off and the ward boy say, वो दूसरा कोई label उस पे चिपका के भेज देगा, नहीं तो मुझे बत्ती मिलेगी. So when you do the test right at the bedside, there is no question of a mix-up of the samples. You have very positive patient identification. Second, of course, is the elimination of a need for specimen transport. And we know that sometimes when a specimen is transported incorrectly to the lab, suppose it is shaken a lot, then the blood will lyse. If it's a urine culture which you kept not refrigerated before you transport, then you'll get an abnormal colony count, and so on. There are so many reasons. The samples has to be properly preserved and transported. And there are many mistakes that can happen at this. That is obviously eliminated if you're doing the test right at the bedside of the patient. Thirdly is the fact that most of the point of care tests are miniaturized. You just need very minimal blood or whatever specimen volume. You can usually do with one drop of blood or so on. And sometimes you can even have non-invasive tests, which I will look at in my talk. Also, the fact that most of the time the blood is directly collected onto the instrument or the slide or the kit or whatever you are using. So you don't really have to collect it in a syringe or transfer it to a tube. You don't have to centrifuge it. You just simply collect the blood, maybe from a pinprick, just directly put it on the kit and you can process the sample. Next is the fact that there's a reduction in transcription errors. When you send something to the lab and there's a technician who does it either on a machine or manually, and then that technician has to write down the report on the patient's paper or on the report. Sometimes there's transcription error. We are all humans. Instead of writing a blood sugar of, say, 68, she might write 86. Or instead of 124, might write 142. These kind of errors can happen. These we call transcription errors. And they obviously will be eliminated because you're directly seeing the report with your own eyes. Next is the fact that the testing is done in the patient's presence. So the patient seems very happy, he's very satisfied. Because if I send a blood sample to the lab, next day the patient gets a report or you call the patient and say, oh, aapko malaria hai. And the patient is like, okay, doctor's telling me this or the lab is telling me this. But I mean, is there some problem? Has the sample properly gone? Has it been properly processed? Oh, mera hi sample hai na. All these may cause some certain amount of dissatisfaction or query in the patient's mind, which does not happen if the test is done directly in the patient's presence. Many of the point of care tests are cheaper than doing it in the lab. And also because you're doing a test which can be like a screening test, which can determine that, okay, now I know which is the next test that I need to do to clarify or confirm the diagnosis. And therefore, instead of doing a whole battery of tests, you see nowadays we have, for example, a fever panel that you can do. Yes, you test for everything together, but that costs the patients a lot of money. So if you do a simple test which can say indicate that this might be malaria, then you can simply do only a malaria test and therefore this saves money. So these are the additional advantages of a point of care test. Now, why are they particularly relevant to our country? Now, we know that many testing laboratories, particularly in rural areas or in the hinterland, they don't exist. And if they are far away, you can say, okay, kya ho gaya? Transport ho sakta hai. Bhiwandi say sample can come to Thana and get examined by a lab there. But we know that there are challenges in this. I already told you about the problems in deterioration of the sample quality during transport. Then you have to organize the transport. Somebody has to take it there. And of course, there is of course a delay then in sending the report back to the physician from the lab. So also the fact that many rural areas may have a laboratory, but I think we all agree that they are unreliable. They are run by unqualified or poorly qualified personnel who have absolutely no idea of something we call quality control, which is really required for good, reliable results. So for all these reasons, if you are in the periphery, you don't have a good lab nearby, and you want to test what is the harm or what is the, in fact, the great advantage if you can do the test at the patient's bedside and get a result. But we need to be sure that the tests that we do as a point of care test has to fulfill certain criteria so that they are useful and they are good, they are quality. And these have been identified or listed down as they have to be affordable, they have to be sensitive as well as specific, they have to be user friendly. You don't want a doctor trying to fumble around using a complicated instrument, trying to conduct a test. If he does that and doesn't do it properly, he's going to get a wrong result. They have to be rapid and robust. The results have to be reliable. They have to be rapid. As I mentioned earlier, we want an answer within a few minutes. And of course, the equipment used should be as small or as less or as uncomplicated as possible. The best would be without any equipment, just a strip or a paper or something like that you can just put a sample on and get a result. So these are the quality criteria for a point of care test. Now, where can we use a point of care test? Where can they be useful? They can be useful in inpatient care. You say, what's the harm? Inpatient care, we can just draw a sample, send it. But many small hospitals don't have their own laboratory. Then they have to send it out. Many hospitals have their own lab, but the lab may not work at night or on Sundays or other situations. Then when the patient is getting admitted at emergency, you may want a quick answer because the patient is very sick or critical. You don't want to collect a sample, send it to the lab, transport problems, ward by chai pee raha hai, wo kabhi report aayega pata nahi. You want an answer immediately. Similar quick answers may be required in an operation theater because the patient is suddenly crashing, and in an ICU when you know the patient is already very critical. These are situations where we want a quick answer. In an outpatient care also, we can use in an outpatient clinic. For example, a patient has come to you. Can you mute yourself, please? So when the patient has come to your outpatient and you say, for example, I think this patient has got a UTI. Can I have a quick answer? Yes, if I have, for example, a dipstick slide test, then I can quickly at least think whether this patient is likely to have a UTI or not. And in 10 minutes, I have an answer. And then the further step can be done. Should I start an antibiotic? Should I send a urine for culture? Does the patient need hospitalization? Does the patient need a sonography? And so on. Answers are available at your fingertips in 10 minutes. Similarly, when the patient is at home, suppose he's bedridden, he's elderly, cannot travel. If you go at the patient's home and you can have a quick answer in 10 minutes, there's nothing like it. And of course, we know this happened. The last situation is when you don't even have to go to the patient home. The patient tests himself or herself. And we all did this during COVID. We did home testing for COVID. And we can also do home testing for follow-up. For example, you have a diabetic patient, his sugar is high. He can do follow-up sugars at home and find out whether he's well controlled, his sugars are high, low, or is he hypoglycemic and so on. And so many other tests can also be done at home. A woman wants to know whether she's pregnant. You can do a point of care test at home in her urine and find out whether she's pregnant or no. So these are situations where you can use a point of care test. Then I come to what are the commonly used tests that I'm going to talk about. I think you know that the commonest point of care test is a blood glucometer. Blood glucose monitoring is now ubiquitous. There are lakhs of such devices that are being used at patients' homes, in laboratories, in emergency rooms, in doctors' clinics, even on the battlefield and at airports or wherever, so many places where you deal with an emergency patient, you need to use this equipment, and it's so very useful and pretty reliable. The other one I want to talk about to tell you that everything is not always hunky-dory is a handheld neonatal bilirubinometer. I think you know that neonates get jaundice, and we are worried when neonates get jaundice because they can develop a condition called kernicterus, where the bilirubin can damage the neonate's brain. And you need a quick answer to decide whether this patient needs to be hospitalized, this baby needs phototherapy, or needs an exchange transfusion or whatever. So in the West, they devised this instrument that you see somebody holding on the baby's forehead, where you have a quick answer of what is the approximate level of serum bilirubin in the baby's blood. So you can make a decision on the questions that I proposed earlier about hospitalization, treatment, and so on. Now, this was very widely used and still used today in the Western neonatal nurseries. But we can't simply use it in India because we are dark skinned. So the color, the melanin in the skin, the dark color of the skin interferes with this test. So just to point out to you that everything that works abroad may not necessarily work here. And we need to be aware of that instead of simply importing Western technology. I mentioned this to you a little earlier about a urine dipstick. I don't know how many of you use this in your clinic, but I think you know that many diabetics can use a modified version of this to check sugar in their urine. Many patients with chronic renal disease or kidney diseases like nephrotic syndrome can use one at home to test whether they are passing protein in their urine or not. But this is the full dipstick where you have several things all in one strip. You simply dip the strip in the urine, freshly voided urine, and you have a color-coded strip which can tell you all these criteria: the specific gravity, the pH, the presence of leukocytes, presence of blood, presence of nitrites, ketones, bilirubin, urobilinogen, and so on. And so many things, and glucose and so on, that you can find, which tells you a wealth of information in a few minutes. So this is useful for proteinuria monitoring in a nephrotic syndrome child, sugar monitoring in a patient who's got diabetes or who's taking steroids high dose. They're worried whether his sugar is going too high. To look for hematuria in a patient with a chronic uh, nephritis, like for example, systemic lupus erythematosus. You're worried whether the patient is anytime going to develop hematuria and so on. But I think for infectious disease and in pediatrics, very useful is the leukocyte esterase and the nitrite test. That's the leukocyte esterase, and this one is the nitrite. And you get a color coding from clear white to pink or almost purple, and that's the semi-quantitative grading. So presence of pus is determined by the leukocyte esterase test. And this is the sensitivity and the specificity of this test. So when you have nitrite positive, the sensitivity of this test is 45 to 60%. That is still 50% chance only that you are right, that this patient has a UTI. I mean, a patient with UTI has 50% chance of showing you this nitrite positive. But if the test is positive, the specificity is pretty good. It's over 85%. That means if the test is positive, most likely the patient has a urinary tract infection. Similarly, the leukocyte esterase test, that is the one at the top, this purple one, this is the sensitivity, again, barely 50% to around 85%. Specificity is highly variable. You will say, then what is the use if there is so much variation? What we do is we combine both the tests. If the leukocyte esterase and the nitrite are both positive, then the sensitivity is very high, 68 to 88%, and therefore this test is useful in saying that yes, this patient is likely to have a UTI. The other test that I want to talk to you about, which we don't use so commonly but is pretty useful in children particularly, is the rapid antigen detection test for streptococcal sore throat. Children come to you with fever and difficulty in swallowing, and you look at the throat, it looks red. We know this can happen in both bacterial infection, that is streptococcal sore throat, which we know can have a lot of complications like rheumatic fever or a quinsy, paratonsillar abscess, and so on, and a simple viral sore throat, which need nothing except paracetamol and gargling. So this test helps you to distinguish the viral from the bacterial. It can identify the streptococcal infection very immediately. There's a test cassette here. You take a swab, put it on in this chamber here, and you can quickly find out whether it is strep or not. So Westerners use this a lot. It's not so commonly used in India. Advantage, of course, you can immediately decide whether the patient needs an antibiotic for the streptococcus or not. It's of course cheaper than doing a throat culture, and of course much more rapid than doing a throat culture, which you know takes 2-3 days. Disadvantages are the false negatives can occur. So in case you strongly suspect a streptococcus sore throat, you may have to follow up with a culture. However, false positives are rare. So if it is positive, if the test is positive, you can directly start an antibiotic. And this is what the steps of the tests are. You simply put the drop of the reagent, you take the throat swab, you rub the throat swab on that, and then you take the reading like this. You see these bands, and if the bands are positive, that means this patient has got streptococcal sore throat, and therefore you can immediately start a practice. And if it's negative, you can avoid antibiotics. So it's good for antimicrobial stewardship. We know that we have these rapid malarial antigen tests, which normally we ask the lab to do, but they are simple enough and quick enough for you to do at the bedside if you wish. We need to remember that there are two types of tests: the HRP2 antigen test, which is specific for P. falciparum, but it is also positive in a dead or dying parasite for several days. So you cannot tell you whether the patient is responding to your treatment or not. On the other hand, the other, again, point of care test is the parasite LDH test, which detects the parasite LDH, which is secreted by a living Plasmodium parasite. It also has the advantage that it can separately identify P. vivax from P. falciparum, and therefore you can modify your treatment accordingly, and also, of course, the prognosis, because we know that falciparum malaria is much more prone to complications than Plasmodium vivax. The sensitivity of these tests is pretty good. That means your chances of missing are only 15 to 5%, and the specificity is near 100%. In other words, if the test is positive, you are certain that your patient has the disease and you can directly start treatment. We also have this rapid test for dengue. Again, you normally send this to the lab, but this is simple enough, cheap enough, and easy enough to do it in your clinic. And you'll have the answer in 10 minutes instead of waiting for the lab to give you the report after a few hours. You have a test, point of care test, that will detect the NS1 antigen, which is the antigen from the virus, as well as the IgM and the IgG antibodies. You can do it on the whole blood, serum, or plasma sample, so it's easy to use. Since you can do it in whole blood, you don't even need to centrifuge the sample that you get. It uses the immunochromatographic method in something we call a lateral flow cassette. That's what it is, looks like. Where the sample is put here, it flows into this chamber, and then there are these lines that appear there, and you get a result in less than 30 minutes. It's pretty accurate, 80% for the NS1 antigen or IgM, and 95% for the, if you combine both. And since the cassette has all three in one, you can use a simple single cassette to have a combined result. The disadvantage, the fact that you can miss 20% of patients because accuracy is only 80%, and 5% if you do both. But again, the problem in 5% for both is the fact that we know that the NS1 is positive only in the first 3 or 4 days, whereas the IgM doesn't become positive till the 5th day. So it's nice to say that 95% both together, but we know that the timing of both these tests should be different, and therefore it's not as simple as what is put here. The other disadvantage is the fact that it does not give you quantitative value. It tells you yes or no. है कि नहीं है, positive है या नहीं है. And so why is this important? It's important only for the IgG, because we know that if the IgG to dengue is very high, it suggests that this patient is likely to develop a complication like the dengue shock syndrome and so on. So it's important to have a quantitative value for the IgG. HIV testing, it's useful for in emergencies. Suppose a patient has come for an emergency blood donation or wants a transfusion. Pre-op testing, we found a patient on the road traffic accident, he needs emergency surgery. You want to know his HIV status. A mother has come at term for delivery. She doesn't have an HIV report. So we want to know in these situations the HIV report immediately, so you can do a point of care test. We have a kit available for both HIV-1 and HIV-2, but we need to remember that it tests for the antibody, not the HIV virus antigen itself. And there we know that after you get an HIV infection, it takes 3 to 6 weeks to produce an antibody. This is what we call the window period. So you can miss an HIV positive patient if you happen to do this test in the window period. So how do you get around this problem? You test for the antigen itself if you have a high suspicion, and there's a point of care test available from a company called LRA. And this, of course, will not miss the window period. You also have tests that can check, for example, the CD4 count. And those of you who are involved in treating HIV patients will know that this is something we like to follow up to see whether the patient is responding to the treatment or developing resistance or drug failure and so on. So for example, you can combine point of care tests to a great advantage. See, for example, we know that HIV and tuberculosis can go hand in hand, and there are patients with HIV who are more prone to tuberculosis. And we also know that if a patient has got tuberculosis, we want to know whether you got HIV because there are implications in the treatment. So a country like South Africa had the same situation. I think, South Africa has an HIV prevalence 15 times what we have. It's almost 15% of the population is HIV positive. And of course, they have a lot of TB. So they had to check whether the patient is on treatment for HIV and tuberculosis both. And they had to test everything all in one test at the point of care because many of their patients were in the villages. So they devised a point of care test combined, which look for lactate, because that's one of the side effects that you get with heart therapy, CD4 count to find out the efficacy of the therapy, HIV mRNA viral load to tell you whether the patient is responding or not, and for TB itself, a gene expert test. So they could prepare an integrated point of care test for all these several tests, which is a tailor-made depending on their clinical situation. So we can do this kind of test. We can combine diverse tests onto a single platform. Like for example, you have an SLE patient. I'm giving a theoretical example. And we know this patient, we want, for example, what is the CRP in this patient? What is, does the urine have proteinuria? Is the creatinine rising? And we can devise a point of care test to put all these 3 or 4 things that we want to look at on a single platform, and we can do a point of care test. So research is underway for all these kind of situations. There are other point of care tests that we use for infectious disease. We can check for various antigens. For example, I think you know that when the endoscopist does a GI scopy and he suspects an ulcer, he will simply take the fluid out or the sample out from the scope and check for the urease enzyme on the gastric aspirate to check for H. pylori. You can test for reagent antigen in the plasma for syphilis. We have a nucleocapsid protein of strep pneumonia that can be tested in the urine to check whether an adult who has a pneumonia is due to streptococcus or what, because this can change your choice of the antibiotic. You can look for the Clostridium difficile toxin in the stool in a patient of necrotizing enterocolitis. You can look for rotaviral and adenoviral antigen in the stool so that you can avoid an antibiotic in a patient with diarrhea. Neisseria meningitis. In the CSF, you can check for the capsular polysaccharide. And there are various tests available for certain viruses like the SARS virus I already mentioned earlier, the RSV virus and the influenza viruses by a nasopharyngeal swab. But better than looking for the antigen, more specific and more accurate, of course, I think all of you know, is nucleic acid testing. And we have now nucleic acid testing as a point of care test, nasopharyngeal swab for SARS-CoV-2. All of you are aware of the gene expert test for Mycobacterium tuberculosis in the sputum or the gastric aspirate for TB. We have nasopharyngeal swabs for influenza virus A and B. We have a nasopharyngeal swab to look for the respiratory syncytial virus or the RSV, which causes bronchiolitis and other respiratory infections, particularly in pediatrics. And now we've advanced to do what we look for multiple pathogens on a single swab. So this is called as multiplex testing using a PCR array. And we have PCR arrays now. On a nasopharyngeal swab, we can test for 14 different respiratory viruses, as well as bacteria and organisms like mycoplasma, which cannot, I think, cannot be cultured in the laboratory. We have a similar multiple PCR array. There are various companies. The one common one that you might all be familiar with, something called BioFires. You simply use this multiplex array on the stool and it will identify you whether it's Salmonella, whether it's E. coli, whether it's rotavirus or whatever, Cryptosporidium, everything on one test. We have a similar meningitis panel. Actually, it's meningitis encephalitis panel. There are 14 different viruses and bacteria that are identified on a single array. There's a blood panel also which you can test on a blood culture which is growing in your laboratory. You can't directly do it on the blood sample, but once the laboratory is growing an organism in their plate or in their broth, you can simply take that and use this to identify the organism. And we have progressed now to, you say, yes, of complicated is all can be done in the laboratory, but it's being simplified now so that it actually now can become a point of care test. We have what is called cartridge-based PCR testing. It's an automated machine. You see this machine here on the right. This is the Gene Expert machine. And it's small enough actually to be brought to the bedside of the patient. It's simple to use. It can also, I think, picks up drug resistance. And this has revolutionized the diagnosis and management of tuberculosis. And we can extend it to so many other pathogens now. There is a Gene Expert test available for gram-negative organisms, for staphylococcus, and so on. And you can do this at the bedside because it's so easy to use. It's so easy to use and so small. We have PCR machines now which are the size of a typewriter. They weigh only a couple of few kilograms. They are easy to transport. They just require a simple 230-volt power source, which all of us have, and can reliably run 40 cycles of PCR in 20 minutes. And you also have machines that are what we call open PCR. That is, you can use the same machine for testing for a PCR for TB, for a gram-negative organism, for staphylococcus, for a virus, and so on. Depending on which cartridge you use or which reagents you use, you can use the same machine for any DNA RNA test. So this is now a reality now, and it's pretty easy to use for a physician with very minimal training. It's so easy that I put this slide here. Many of you might remember this Hero Honda ad, which they advertise that it's so easy to fill petrol in your motorcycle now. It says fill it, shut it, and forget it, because you just fill it, start it, and it just keeps on running. And actually the PCR machine, the Gene Expert machine, will even print out the report for you. You don't have to do anything. You just look at the printed report. So desktop PCR machines are here and they can be point of care tests. And besides PCR machines, we have other useful tests, and I'm again going to talk because of my favorite topic on infectious disease. We have bedside CRP and procalcitonin testing. This is what they look like. They're very small instruments, handheld, battery operated. You simply drop a patient blood here and you have the answer. You have microcoulter counters, this size here. This is the actual size, and you can do a CBC in your consulting room. A point of care test. You can also, many of you might have used this in the past. You do a Buffy coat testing for malaria. Again, of course, this machine is not that small, but it's about the size of a little large, size of a computer, which you can put a desktop computer, and you can check for malaria in your clinic without sending the sample anywhere. So this is the reality today. This is what we are already doing. Now let's talk a little bit about what is the future of point of care testing. The future paradigm, which I see will happen in a decade from now, is that we are going to say that the current diagnostic laboratory system of having a lab testing where you send your samples and get a result is a hangover from half a century ago. We need to change, and we will change within a decade, to a more patient-centered system where you do personalized medicine and companion diagnostics all at the patient's bedside, so that the treating physician also has more control of the diagnostics. You don't have to wait for the lab for you to send a sample, and then they may say, "Oi, aaj nahi hota hai, hafte mein 2 दिन ही करते हैं. We do only on Mondays and Thursdays, or we have run out of this reagent, or this reagent is in short supply, or the technician who does this test is on leave." You don't have to wait on. You have full control on doing the test yourself. And this is the kind of future that you're going to see. What is meant by patient centralized diagnostics? The patient comes to you, the physician yourself, draw a sample. You're going to look at the patient's sample. Usually it's the blood, but we might in future even use saliva, you might use tears, you might use urine, and so on. I think that is even there is now a test available for HIV in the saliva. And you can check for viruses, nucleic acid, DNA, RNA, proteins, IgG, IgM. And you have a whole point of care test toolbox with you. You have microfluidics, you have paper assays, You have this lateral flow, that is the ICT that I just showed you, which you use for dengue and malaria. We have compact molecular desktop systems like the PCR machine I showed you, which you can just put on your desk table, small size, typewriter size that you can use, and maybe even plasmonic and nanotechnology in the future, where you have very small machines that will allow you to give you an answer so that you can do very timely personalized therapy. You have an answer of what is the diagnosis, and you immediately treat the patient with the correct medication. And point of care tests are growing at a very rapid pace. The test menu is expanding, and within few years, you will see many more tests coming that you can use at the patient's bedside. How big is this going to be? How big is the point of care testing market? And I'll show you how. This is the data of 2021. This, of course, is from the United States. But you see point of care tests being used. Majority is for infectious disease. 43.9% is infectious disease. A large amount is, of course, for blood glucose testing. That's simply because there are a lot of diabetics worldwide and they need to test sugar all the time at home or in the clinic or wherever. Then there's also point of care tests coming for cardiometabolic disease. You have a patient who comes to you with angina. You want to know whether it's a simple angina or already an infarct. You can check a CRP, a micro CRP at your bedside or immediately so that you can decide whether the patient needs to go to the ICU or just can go home on some anti-angina treatment. Pregnancy and fertility testing, of course, I told you, point of care test for pregnancy testing is already available for even home use. Hematology testing, I told you about CBC and other things. And there are so many other tests that are being available. How big is the market? The market is expected to be 50 billion US dollars by 2029. So in the next 5 years, point of care tests are going to become a huge thing. And we all better get onto the bandwagon before we miss the boat. We need to know how we can use this test judiciously. So what should be our approach to this point of care test that I just told you about? We need to keep up to date with whatever newer point of care tests are available. And as I told you, the menu is going to keep on expanding and expanding very rapidly. Every few months, a new test will be available. We need to be aware of whether they are useful, where they are useful, how accurate they are they really good? Because companies will put anything out in the market for profits. We need to be aware how good they are. And we are already facing this situation with, for example, dengue tests. I know there are certain dengue rapid test kits that are not as reliable, not as accurate as those prepared by other companies. So we have to be aware of all this if you're going to use them yourself. Currently, this problem rests with the laboratory because they're the ones who are using it. But if you are going to use it, you need to know which company's kit you're going to buy. We need to learn to use them correctly. There's a little methodology of how the blood is to be taken, how much is to be put, when it is to be read, and so on. And also, we need to decide in which patient at what time I'm going to do which test. Just because they're available, we can't use them on every patient. The other thing that's going to happen now is that because you are doing the test, and the test is going to come in the form of a strip or a line or a number that you're going to read, it is your job now to document the test, to write it down on the patient's paper and sign. You have to validate it so that there is a record, because otherwise that strip or that kit is gone. It is discarded. So where is the answer that this test has been done? And I know this is a situation. Because I have a patient who comes to me, a baby who's 3-4 months of age, and the mother tells me that this child was admitted in the newborn period because he was drowsy, and the doctor said that iska sugar bahut kam tha. And I go through the entire discharge paper. There are certain blood reports about ketones, about one blood sugar, which is normal because obviously it has been done later when the patient has received IV. And some other tests might have been done to look for infection or whatever. And the initial hypoglycemia report must have been a point of care test done at the bedside in the casualty or in the emergency. There is no record of that at all. So we don't have any sort of validation or any confirmation that this patient actually had hypoglycemia, and whether it was in the 40, whether it was 20, whether it was 55, there is no report. So the onus is on us to record a test that is done at the point of care test. And lastly, if you think the patient is hypoglycemic and you've done a sugar and your strip is saying 85, then if there is some discordance, we need to be aware that we should not necessarily rely on the point of care test and cross-check with a lab-based test. In future, what we can expect from point of care tests, we can expect that they're going to get better and better. They're going to get more accurate, more reliable. In other words, the sensitivity and the specificity is going to improve. They're going to become easier to use. Currently, some of them are a little complex. Even the gene expert test requires a little bit processing of the sample, and then you have to put it in the cartridge. But later on, as I said, you just put it and then the machine runs everything. So they'll become even more simpler to use so that a physician who's not properly trained in laboratory work can do it at the bedside. They're going to get cheaper. The cost of each test is going to go down. The size of the equipment is going to get smaller. Miniaturization is the answer. I think you all know that and a mobile phone now is so much smaller and going to do so much more than the bulky equipment that we used 20 years ago. Why is this important? Because if you're going to keep it in your clinic, you want to use minimal space. If you want to carry it from one room to another, it has to be small in size. So that's going to be a big advantage. And also the fact that finally, we're going to have point of care test results that can be integrated into electronic databases. We already have point of care tests that you can plug into your phone, your cellular phone, your smartphone. You know, they all have a C port which you use for charging. You can plug a point of care test into that. So you can use the processing power of your phone to process the result and also to record the result in some document on your phone. So this is what we mean by integration of the point of care result into an actual database where you can store the result. So to summarize, there's a growing menu of tests in point of care tests, and they're going to be a massive growth even in the future. So we're going to see increased applications both in the inpatient as well as the outpatient settings. As clinicians, we need to understand the value and the limitations of point of care tests. We should be able to use them in an appropriate patient populations. So for optimum usage, and we need to be really aware of how to interpret the results correctly. Guidelines are available. There are now guidelines available in the United States. We tell you how to use a point of care test, when to use it. They are a valuable source of information. We need to be aware of them. We need to read them and need to follow them. And as I said, the future is beckoning. New applications and technologies are there. They pose both challenges and opportunities. We should be aware of how to deal with them. Thank you so much. If there are any questions in the chat box, I can answer them, or you can ask the questions verbally.
Sure, sir.
Can you read out any questions in the chat box if there are?
There was one question where they were asking for the price of the machine, I think, which was very.
It's very important. India is quality conscious, but again, price conscious. But as I said, it depends on who is making it. Imported machines are obviously more expensive. Currently, a lot of them are imported, but I don't underestimate Indian companies. We are soon going to have Indian companies which are going to make many of these tests. I think you know that blood glucose monitoring has also become pretty cheap. But again, the commonest ones, I think, you know, are by the multinationals, and they're still pretty expensive. But cost will come down. So cost will depend on whether they are imported or whether they're made in India. And also, as I mentioned earlier, quality. You can get cheaper ones, but they may not be very reliable. And you might go wrong if you use them to treat the patient. We should also be always aware that price is not everything. Sometimes you have to pay for quality. I I must tell you that there is a shop in my neighboring building. He is not a medical shop. He sells some other stuff. But he's got a board in his clinic, which I think is very relevant to the question asked. The board says, we have no competition, no quarrel with competitors who charge less. They know what their product is worth. What does it mean? It means that if you want a good product, you may have to pay a little more. So
Right.
prices will be variable. but prices will come down, as I said. Thank you.
So apart from everyone thanking you, there are no more questions. But if anything is there, we'll take it up and maybe we'll connect with you and give them the information. So as remember in the beginning, you mentioned that you're thankful that you're getting to speak on a topic which you wanted. I
Yes.
think we should be thankful that you have chosen something so unique which we would have not thought of, and every slide was a gem of knowledge, and I'm very certain that our participants, as always, are very happy. They all are continuously mentioning very informative thank you, and really thank you, sir, for enlightening us. And thank you for taking up again and speaking for the family physician as mentioned by sir.
Thank you. But frankly speaking, I had very little choice of topic because I had to take a topic which would be useful to non-pediatricians and not just pediatricians. So no point in talking about how to treat bronchiolitis or how to treat diarrhea in children. So I chose a topic that would be useful to everybody. I hope it was. But somebody has raised their hand.
Yes, Dr. Usha has raised it. Dr.
Yes,
Usha,
Dr.
if you
Usha,
can,
you have a question to ask?
Doctor, if you
Maybe
can put it
unmute
in the
yourself and
chat,
ask.
would be helpful.
Sorry?
Just Dr. Usha is, I'm just trying to unmute her. Dr. Usha, if you can put it in the chat, sir will answer your question.
Or maybe she's pressed the button by mistake. She doesn't actually intend to ask anything. That's possible.
Probably, sir.
Okay. So if there are no more questions, I'll take your leave. I think we are nearing 1 hour anyway.
Right, sir.
And doctors have to go to their clinic. Their patients are waiting for them. So I thank all the doctors for taking an hour off to come and listen to me. There's no sense in talking unless somebody is listening. So thank you very much.
No, sir, it was all our pleasure, and it is like assure which you mentioned. We are assured, they all are assured of the knowledge you imparted today. Thank you so
Okay.
much, sir. And
Thank
thank
you
you
so
all
much.
the participants to be there till the end. They almost like joined half an hour earlier, and they are still there. So thank you all, and thank you, sir, so much once again.
Thank you. Thank you. Good night.
Good night, sir.